Hello, welcome everyone. My name is Ellen Hostetler. I'm the Chief Science Officer for the John Ritter Foundation for Aortic Health. I'm just going to wait 1 minute here for folks to come in from the waiting room, but then we'll go ahead and get started because we have a lot of great content today and speakers, and I know you all have some questions. So I'll get right into it after just a minute here. But please feel free to introduce yourself in the chat. That's available in the Q&A. Let me just make sure that the chat is open for everyone to be able to type in. Should be open now. And if you want to put maybe where you're located or anything you'd like to share, please feel free to, or ask questions in the Q&A, as I mentioned. And Bella Marin is here. So Bella is our patient and advocacy coordinator at the foundation. She's a registered nurse and she runs our Aortic Advocate program. So if you write into us with questions, you'll probably get Bella writing you back. So thanks for being here in the chat, Bella, to help out with any questions people have. Okay, so I'm going to go ahead and get started and do just the briefest of intro. Hopefully this will work for me. Okay, oops. So as I mentioned, please use the Q&A to ask questions. We do have a few polls throughout, so we'd appreciate your participation if you're willing. And this webinar is being recorded and will be posted on our YouTube channel when it's available. That link will be emailed to you as well if you registered for today's session. Just be kind and polite in the chat as always, and thank you for being with us. This is a short disclaimer. I'm not going to read it all, but essentially the information that's being presented in this webinar is for educational purposes only. It should not be used to change your medical care, make decisions about your medical care. Please always consult with your own medical team before making any of those decisions. If you'd like to read this disclaimer in more detail, it is available on our website. And we have three wonderful speakers today who I will introduce at the end here, just because they have amazing accomplished bios. So I want to read it to make sure I get the details right. But I'll let them go through their presentation, and at the end, they're all happy to answer questions. So please stay tuned to that if you have something specific you'd like to ask them. And finally, just to save the date for our next webinar, which is March 19th, 2025 at 5 p.m. Eastern. And Dr. Siddharth Prakash, who many of you know if you've been with the webinars for the foundation, will be sharing results from the clinical trial of exercise in dissection patients that was funded by the John Ritter Foundation. So this is really exciting. We know for a lot of you living with aortic disease, and probably a lot of folks on this call who have active lifestyles and jobs and professions, that this is a big question you all have. And we're really excited to be getting the first data out of this 2-year trial that's been complete. So please save the date for this. This registration will be available on our website and social media and via newsletter and all these places next week. So with that, let me do my little intro here for our speakers today. We have three wonderful speakers, as I mentioned, all of whom are certified genetic counselors and assistant professors of medicine at the Uniform Services University. First, Austin Pagani. Hopefully I said that right. I practiced it before. She works for the Center for Military Precision Health through the Henry Jackson Foundation with military patients and families with inherited cardiovascular conditions. And she supports postmortem genetic testing services through the USU MCAP program. She's also involved in genomic research projects related to sudden cardiac arrest, pharmacogenetics, and other conditions which intersect with genomic medicine. Next, I have Emma Schopp. She works with the Military Cardiovascular Research Program and provides genetic counseling for people with inherited heart conditions at the Walter Reed National Military Center and supports military families considering postmortem genetic testing following sudden loss. She also conducts research in cardiogenomics, sudden death, and research participation in decision-making. And last but not least, we have Dr. Lydia Hellwig. She's an investigator and counselor for many genomic research projects, including genomic medicine implementation studies, as well as studies that seek to better understand sudden cardiac death, cancer, and other diseases. She also strives to increase genomic literacy and is passionate about clinical genetics education. So thank you so much to the three of you for being here. I'm going to turn it over to you to present. And please, as I said, feel free to ask questions and I'll monitor the chat.
Perfect. Thank you so much, Ellen, for that introduction. Just before you go off mute, let me know if you can see my slides.
Looks great to me.
Okay, great. So again, thank you so much for introducing us and setting this up. Dr. Hellwig and Emma and myself are all very excited to be here with you all today to talk about care for inherited aortic disease in the military health system. And this is a system where we know there are some unique benefits and special considerations that we'll be discussing further today. Also, before we begin, we'd like to sincerely thank the John Ritter Foundation for Aortic Health for inviting us to speak with you all today. Before we get started as well, we have no conflicts of interest to declare, and the opinions and assertions expressed here are our own and do not reflect the official policy or position of the Uniformed Services University or any of the other entities listed here. In terms of learning objectives, we hope today to be able to describe for you all the military health system and identify some military-specific implications of genetic testing and genetic information. We also aim to describe the clinical cardiogenetic services that currently exist in the military health system, and lastly, discuss postmortem genetic testing resources and availability in our system as well. And so to obtain those objectives, I'll start with a very brief introduction to genetics and aortic disease, and then I'll hand it over to Dr. Hellwig, who's going to go over some overview of the military health system, as well as some military-specific considerations when it comes to genetic information. I'll then talk about cardiogenetics care for living military health system beneficiaries, and then Emma is going to discuss some important information regarding postmortem genetic testing in our system. We hope today provides some new and helpful insight into genetics care in the military health system. And at the end, we'd love to answer any questions that you all might have. As Ellen had mentioned before, we also have a couple polls just sprinkled throughout today's presentation that, of course, we'll hope you will participate in. Ellen, feel free to launch the poll. Once that poll launches, you should get a pop-up within your Zoom window. If for whatever reason it doesn't work for you, feel free to put your answer in the chat as well. And hopefully we'll be able to see some of these results as they come in. The first question is really just getting at why you're interested in learning about aortic disease today. I'll give everyone just a little bit of time to answer. I'm not seeing any information yet, but I think whenever we want to close the poll, we'll be able to see that pop up.
Yeah, I'm just going to wait till we get to 50% participation.
Okay, perfect.
And you'll see the results. All right. Looks like we're over 60 now, so I'll end it and share the results.
Great. Thanks, everyone, for participating. I think you all can see this information as well. It looks like there's people coming kind of from all backgrounds and experiences with aortic disease. Some people have a history of aortic dilation or aneurysm themselves or a history of aortic dissection, whereas other people have family members or are healthcare providers that work in the thoracic aortic space. Looks like our second poll also went through, which was looking at why you're interested in learning about the military health system. So some people, again, have experience as an active duty service member or a military health system beneficiary. And then other people are healthcare providers associated with our system. So it's great to see lots of different people joining with different experiences. Hopefully that'll be helpful in terms of all of the different contexts we have for today's talk. Again, thank you all so much for participating. I'm going to move forward past this poll since we already answered that one, and then get into talking a little bit about genetics in clinical care. I think a really big misconception about genetics or the field of genetics is that genetic conditions are really rare. And individually, most genetic conditions are quite rare, but collectively, genetic conditions are actually quite common. And we think that more than 1 in 200 people in the general population have a hereditary health condition. This Friday, February 28th, is actually Rare Disease Day. So it's a day to celebrate individuals and communities that have a rare disease. And many of these rare diseases actually have an underlying genetic component. We also know that genetic information is not just information for information's sake. Advancements in the field of genetics have allowed for a more personalized or patient-centered approach to medical management, not only for the primary patient, but for their family members as well. And we hope that this and expect that this will continue to advance in the future. Certainly, genetic testing and genetic counseling are standard of care recommendations and clinical guidelines across many specialties, including cardiology. And I'll actually reference some of these clinical guidelines later in the talk today. And then lastly, we know that the inclusion of genetic testing and genetic information in clinical care can really be life-saving, again, not only for a patient that has a history of aortic disease, but for their family members as well. Now, genomic medicine is really just a broad term that describes this personalized approach to healthcare. I think one of the most familiar examples of genomic medicine is using genetic information to help support a diagnosis of a genetic condition. But really, there's lots of different aspects of genomic medicine, including using that information to guide screening or treatment recommendations, including tailoring medication management for patients. And then certainly genomic medicine and genetic testing information can factor into family planning decisions as well. And so, given how broadly genomic medicine impacts different aspects of healthcare, I think a lot of people are interacting with genomic medicine in their current healthcare without even realizing that's the case. And then I know, and based on the polls, I think a lot of you already have a pretty good understanding of thoracic aortic disease. So I just wanted to really briefly go over some background information on this slide to make sure we're all on the same page. So when we're looking at the aorta, as you all likely know, is the major blood vessel that comes off of the heart that delivers oxygenated blood to the rest of the body. It extends all the way from the chest down to our abdomen. Some individuals may develop an enlargement of part of their aorta. Imagine kind of how a balloon expands when air is blown into it. And that is what we would call an aortic aneurysm. When an individual has an enlargement of part of the aorta or that aortic aneurysm, that can increase the risk for a pretty severe life-threatening outcome, which is what we would call a dissection, where that aorta develops a tear in one of its walls. Importantly, for individuals that we're able to recognize have these aortic aneurysms and are managing appropriately, we can significantly reduce the risk of dissection. Thinking about how common these aortic aneurysms are, the prevalence is estimated to range from about 0.07 to 0.16. And that range really depends on whether you're looking at studies that only look at individuals who are diagnosed with aortic aneurysms while they're living versus studies that also include individuals who are diagnosed probably asymptomatic during their life, but diagnosed on autopsy. And so if we're looking at that higher end of the prevalence estimates for aortic aneurysms, that and applying that to the general US population, there would be up to 500,000 people affected in the US by thoracic aortic disease today. We also know that there are a bunch of different risk factors that can contribute to thoracic aortic disease. So some common examples would be congenital heart defects or structural changes in the heart that someone's born with, like a bicuspid aortic valve or coarctation of the aorta. Additional risk factors include things like uncontrolled hypertension or inflammatory conditions affecting the aorta. And as you all may guess from the focus of our talk today, certainly there can be some genetic impacts or influences on thoracic aortic disease as well. There are some conditions, some genetic conditions that impact only the aorta, so increasing the risk for aortic aneurysms and dissections. And then there are other genetic conditions that increase the risk for those aneurysms and dissections, but also affect similar tissue throughout the rest of the body, leading to increased risk for other health concerns or symptoms. And we often refer to those conditions as syndromic. Some examples of some syndromic conditions include Marfan syndrome or vascular Ehlers-Danlos syndrome. And so I know that was a really brief overview on genetics and aortic disease, but with that, I'm going to turn it over to Dr. Helwig to talk about the military health system, and then we'll circle back to talking about care for aortic disease in our system.
Great. Thank you so much, Austin. That background was really helpful. And so now I'm just going to provide a brief overview of the military health system. I know from our poll, it sounds like some of you may be patients yourselves in the military health system or providers, but I think it's helpful to kind of talk through this, especially for those who may be less familiar with the military health system. So, this is one of the largest health systems in the United States, serving over 9 million beneficiaries, including about 1.3 million active duty service members. And at the core of the mission of the military health system is this concept of readiness, which is really making sure individuals are prepared to execute the core functions and perform their assigned tasks. So, again, ensuring that they're medically fit, able to do their job, and be prepared to do anything that's expected of them. I also like to point out that the military health system is actually a separate system than the Veterans Affairs health system. So these are two different health systems. They serve two very different populations, and they have different policies that are associated with them. So we'll talk through some of that today. When we're thinking about genetic conditions in the military, I think it's really important to understand that genetic conditions affect everyone can affect many people in the population. And so, although we generally think that our military service members are quite healthy and quite fit, and we have pretty stringent fitness requirements, we actually have data to show that the incidence of certain conditions that have significant genetic components can be even higher than in the general population. So some examples of these include incidence of breast and prostate cancer, as well as the incidence of sudden cardiac death. And so among new recruits, the incidence of sudden cardiac death is actually even higher than in NCAA athletes. So again, even more important potentially in this military population for us to be able to better identify those who are at increased risk for certain diseases or disorders that put them at risk for dying suddenly. Again, to maintain our values of force readiness and making sure that we're maximizing healthcare for our patient population. So again, I think that we've talked about ways in which genetics can be really useful to medical management, and that military members also are needing to have access to genetics. And so I think it's important to understand where military members will get access to genetic services. The military health system generally consists of two different types of care. So individuals can receive care in what we call the purchased care sector or the direct care sector. In the direct care setting, this is really where we have military treatment facilities. These are military hospitals in which our beneficiaries may receive care. We have clinical geneticists and genetic counselors in the direct care setting in the military health system, and these are stationed at military treatment facilities across the United States and even across the world. And so they may be seeing patients locally at their military treatment facility, or sometimes can be seeing patients via telehealth as well. In addition, though, service members and families may be seen in the purchase care sector. This is separate from the direct care sector, in which individuals and beneficiaries in the military health system are seeing civilian hospitals and providers in those civilian hospitals. A little bit different in terms of some of the ways in which they have access to certain types of care, and this is really through TRICARE that they are getting access to this. In addition, outside of the military health system, individuals in the military may have additional ways to access genetics. So we know that individuals are participating in things like direct-to-consumer genetic testing, as well as genomic research opportunities. So obviously, there's research happening across the country, and many of these research studies are returning results back to participants. And some of those participants may include military service members. So really important across these different settings that individuals may have an understanding of what the military health system is and what the potential considerations are for this population. And so we're going to talk about some of those military-specific considerations of genetic testing today. In general, we're going to talk about two different considerations. One, regarding the policies relating to genetic information. So I'll talk through the Genetic Information Non-Discrimination Act, which is a federal law that prohibits some type of genetic discrimination. And we'll talk about where this does and where it does not apply. And then we'll also talk through policies that are specific to the military and the military population. And then I'll talk just briefly about some of the additional counseling considerations for this population. There's a very different context here related to military service, the requirements, and some of just things in life that service members are dealing with. And similarly, those unique needs of this population may require some additional resources. So really important to consider when we are consenting or returning results in the healthcare setting related to genetic information. So first, I'm going to talk a little bit about the Genetic Information Non-Discrimination Act, or GINA. This was a law that was signed into effect May 22nd, 2008, and this is a federal law in the US that protects individuals against discrimination based on their personal genetic information as it applies to health insurance, which is Title I, and employment, which is Title II. So we're going to focus today on Title II, which prevents employers from using genetic information in employment decisions, such as hiring, firing, promotions, pay, and job assignments. An important aspect of this law is actually the military is exempt here. The military is actually permitted to use genetic information for some employment decisions. And although it's not exempt from Title I, in the military, the insurance or TRICARE eligibility is contingent upon your employment. So whether or not you're able to join the military or stay in the military may have some second order effects in terms of the insurance that they have access to. However, even though there is this exemption with GINA, there are also military-specific policies that relate to genetic information. And I think of two different types of categories of service members that are important to think through these policies. So first are those who are currently active duty service members. There is policy language related to genetic information for those currently in the military. And so we'll walk through some of those policy pieces today and talk about how this is applicable. There's also this population of individuals who are not currently in the military, but are considering joining the military. And so important to note that the policies and the protections may be a little bit different for these two groups. But for that group, there are medical standards for military service, including appointment, enlistment, or induction. And these standards may list specific personal or family history of certain conditions that are not compatible with service. So for instance, an example of this is there's a specific condition called Lynch syndrome, which is an inherited form of an increased risk to develop certain types of cancer, including colon cancer, and actually is included in both personal and family history of Lynch syndrome being included on this list of things that are maybe not compatible for military service. So I want to talk a little bit about the policies that are for the military specifically as they relate to genetics. And I like to start off with looking at what was available historically in those policies, because I think it's really informative for us to think about for service members and families as they may have some concerns related to these past policies. So this is a DoD instruction from 1996, and as you can see, it specifically calls out an exemption of congenital or hereditary conditions when making a determination about when an individual is separated, whether they'll get disability or other benefits. In addition, there is this second piece from 1999 called the 8-year rule that said that individuals had to be in service entitled to basic pay for at least 8 years in order to kind of, again, be eligible for those potential benefits and disability afterwards. And this is an article from the Los Angeles Times back in 2007 that really describes a case of an Army Ranger who was dismissed from the military. And because he had an inherited cancer predisposition syndrome, the Army actually argued that it bore no responsibility for this condition, and it was kind of designated as a pre-existing prior to service condition. And therefore, when he was separated from the military, he did not receive any disability benefits or health insurance after that. Next slide. Things have dramatically changed since then. There's a lot of updates in the language and the policies regarding genetic information. As you can see here, this is the NDAA from 2008, and you can see there's a couple of key differences. First, that 8-year period is no longer here. There's that they have to have served over 6 months, which is much, much shorter than 8 years. And then instead of talking about congenital or hereditary conditions or risk factors here, we're really focused on this piece here where we're using the term disability. The disability was not noted at the time of the service member's entrance on active duty. And again, even in this lower part, we're talking about potential aggravation of that disease as well. So when we're thinking about disability here, we're not talking about a genetic risk factor that's present. We're mostly talking about if there are physical signs, symptoms, things preventing that service member from doing their duty. And then down at the bottom, I just want to also talk about that aggravation of disease piece that, again, we know that for many of these conditions, there are multiple risk factors to develop a disease, and genetics may just be one component of this. So individuals may have some genetic risk factors, but there may be other risk factors, lifestyle factors, environmental factors, other exposures that can also increase their risk to develop disease. And this is really important to take into account when these types of determinations are being made. Next slide. Great. As I mentioned before, the VA is a separate system from the military health system, but they have also recently updated their language, actually quite recently. And as you can see here, their new language for their policy is really solidifying that once an individual enters the VA system and has a disability rating, that disability rating cannot then be adjusted in the future based on subsequent genetic test results. So again, some more language that's clarifying how genetic testing information may or may not be used. So I think when we're thinking about genetic change and how this may be used by the military, it's important really, again, to make that distinction between what the wording is in the policy. And genetic change itself does not equal disease or disability. Again, when we're thinking about those who have a disease, fitness is really assessed based on disability or inability to perform their duties. If there's something that they are unable to do because of signs, symptoms, presentation, other factors, that's what's really being taken into account. In addition, though, for individuals who might not have disease themselves may be undergoing genetic testing. And typically this is in the case of a known familial variant or a strong family history of a disease, or sometimes if an individual is undergoing genomic testing for something else and a secondary genomic finding, something that could be medically actionable, is identified. And so really important in these cases, again, that there is a discussion of the potential risks and benefits of that information, including the potential military implications. And then furthermore, the context is really important to consider as we're thinking about potential implications of genetic testing. As I mentioned, there are differences in terms of policies related to people who are in the military versus those who are considering joining. Also, how long they've been in, that 6-month mark is important. But also thinking about what is their job and deployability. So really important for military members that this information may be considered in terms of how this might impact their ability to be deployed, and specifically whether or not they'd have access to care or other things that they need in austere environments that they may be needed to do as part of their military service. So we've talked a little bit about some of the policy specific implications related to military service, but again, there are also genetic counseling considerations that are important for this specific population. And so the needs and the resources that they may want to have access to may look a little bit different because of this military service. And so we've put together just a couple of highlighted cases and highlighted counseling considerations in this article. So if you want to learn more about that, you can visit this. But I think the big piece here too is that these are really important things for healthcare providers and genetic counselors to be aware of. And if you're a patient and in the military health system and you're looking for resources, certainly reaching out to a genetic counselor in the military health system may be helpful in terms of making sure you're getting access to the resources that you need to navigate this. So I'm going to turn it over to Emma now, who is going to to Austin now, who is now going to talk about caring for military families with aortic disease, specifically in our military health system.
Great. Thank you so much, Lydia. And like I said before, we're just going to connect it back to that brief introduction that we talked about before on thoracic aortic disease, kind of taking into account what Lydia had shared with us about military-specific considerations in this population. So we apply our prevalence from earlier about thoracic aortic aneurysms to the military health system. We would estimate that there's up to 14,000 people affected currently in the military health system by thoracic aortic disease, including some active duty service members. And given that aortic imaging for first-degree relatives, it's a class 1 recommendation based off of current aortic management guidelines. There are many thousands more individuals in the military health system that would be predicted to have their care influenced by this family history of thoracic aortic disease. We certainly know that genetic testing is a central recommendation in current guidelines for individuals with thoracic aortic disease. And you can see to the figure on the right, it really is a central piece of this flow. So a lot of individuals, the majority of individuals who have a history of thoracic aortic disease might be recommended to have genetic testing. And that can be because it can impact not only their management, but family member management as well. The yield of genetic testing in cases of familial thoracic aortic aneurysms or dissections is estimated to be about 20 to 30%. But this yield does increase if there's a clinical diagnosis or specific concern for a syndromic condition like Marfan syndrome, BEDS, or Loeys-Dietz syndrome. And then we'll talk through how genetic testing can really impact patient and family member care. So if an underlying genetic risk factor is identified, that can help guide an individual who has an aortic aneurysm, help guide their clinical screening recommendations. So for example, if an individual has an aortic aneurysm, should their imaging just be of their aorta, or in some situations, based off of an underlying genetic risk factor, maybe we need to consider broadening that imaging and looking for aneurysms and dissections in other vessels in the body as well. Really importantly, genetic information can also help guide the timing of surgical intervention for aortic repair. And this is really important for what we said at the beginning in preventing those dissections, which are life-threatening events. This is a table, again, pulled from the 2022 Clinical Practice Guidelines on Aortic Management, and you can see that there's different genes associated with increased risk for aortic aneurysms and dissections. And even if there aren't any other risk factors present, having a positive result in one of these genes can influence the timing of when that surgical intervention is recommended. Especially for those more syndromic conditions, an underlying genetic risk factor can help inform additional care, like consideration of other specialists that the individual needs to see or specific exercise recommendations. And then as we've been talking about, this information is really important, not only for an individual who has aortic disease themselves, but also for their family members. If an individual who has aortic disease undergoes genetic testing and an underlying genetic risk factor is identified, that really enables family members to be proactive with their own management if they test positive for that same genetic risk factor, or they might be able to be released from continued aortic surveillance if they do not have that familial variant. So it can be really important for multiple different reasons. So I'm going to pause here and we're going to look at our third poll, which is if you have a history of aortic disease yourself, have you ever had genetic testing before? I'll give everyone, again, just a little bit of time to answer that. Perfect. Looks like Ellen shared the results with us. So a lot of people joining today said it wasn't applicable for them, but for individuals that do have a history of aortic disease, it looks like some people have had genetic testing and some people have not. So I think that's a pretty fair estimation of kind of what happens in the clinical space as well. Some patients have been offered this testing and other people may not have. And so let's talk a little bit about utilization. Given what we were just talking about with how valuable genetic information can be to a patient and family member's management, you would think that this care is routinely incorporated into healthcare practices. Even if an individual decides not to do testing, at least being able to offer this testing to individuals with thoracic aortic disease is important. And so Dr. Helwig actually did a study looking at how well genetic testing is utilized in our military health system. So this was a study where she looked at the number of people with a diagnosed hereditary health condition and cardiovascular condition specifically in 2018 that had had genetic counseling or genetic testing. And the results were a little bit shocking. In the military health system, less than 1% of individuals, again, with a diagnosed cardiovascular disease, including thoracic aortic aneurysms or dissections, had had genetic testing or counseling. Unfortunately, this is not unique only to the military health system. Similar studies that have been done in a civilian setting have also shown that genetic testing is being critically underutilized. However, I think kind of the positive spin here is that this poses a huge opportunity for growth in the military health system, especially because our system is unique in that we provide universal healthcare coverage, which can really help mitigate some of the barriers that might be faced in the civilian setting, like cost of testing and just insurance access in general. And so based off of the underutilization of genetic testing, I think this was one of the big drivers for the development of a specific cardiogenetics clinic at Walter Reed within the military health system in 2017. Our clinic is the only multidisciplinary cardiogenetic specific clinic in the military health system currently. And we are located, as Ellen had said at the beginning, in the Bethesda, Maryland area. We primarily see patients locally from Maryland, DC, Virginia, but we do sometimes see patients from across the country, as well as occasionally from across the world. Our clinic is composed of both genetics providers like a geneticist and genetic counselors, as well as cardiology providers, including an adult cardiologist and pediatric cardiologists. And our overall goal is to provide comprehensive care and support to families with different inherited cardiovascular conditions, including thoracic aortic disease. We have a number of different services, and in the vein of thinking about individuals with thoracic aortic disease, I'll just point out a couple here that are relevant. So for patients that come in to see us, if they need imaging, like an echocardiogram, we're able to provide that sometimes for the primary patient or sometimes for their first degree family members, like children that are coming into their appointment with them. We also can provide a physical exam looking specifically for underlying connective tissue disorders, and that can be really beneficial because an individual can receive a clinical diagnosis of a connective tissue disorder, even if genetic testing is negative. And then certainly we talk through pre and post test counseling for these conditions, gather family history, offer genetic testing if it's indicated, and provide other follow-up management recommendations. Vascular conditions are one of the main referral indications for our clinic, as well as we also see patients with arrhythmias, cardiomyopathies, and other inherited cardiac conditions like dyslipidemias. And I'll just note under the vascular referral indications, it's not just a history of aortic aneurysm or dissection or even syndromic conditions. Sometimes we see patients with other arterial aneurysms and dissections as well. And so now I want to just talk through some of the value that our cardiogenetics clinic adds to beneficiaries in the military health system. I think a really big one to start out with is that there's no cost currently for military health system beneficiaries associated with genetic counseling and testing that's being performed at a military treatment facility. Unfortunately, this isn't always the case when a beneficiary gets referred out to see a civilian genetics provider. As Lydia said, sometimes care is received in the direct setting, and sometimes it's received in the purchase care setting. And so if an individual is referred out to that purchase care setting, because TRICARE doesn't recognize currently genetic counselors as TRICARE authorized providers, there may be some costs associated with that appointment. And so that's why one of the reasons I would say it's really helpful that our cardiogenetics clinic is at Walter Reed at a military treatment facility to really remove cost as a barrier for patients trying to access this care. Our clinic, as I mentioned before, is also multidisciplinary. So we have both genetics providers and cardiologists, and having both a pediatric and adult cardiologist is really helpful to allow us to see patients of all ages. Oftentimes, we're offering to see a primary patient, somebody who has an aortic disease themselves, talk about genetic testing with them, and then we're also able to bring in their eligible family members, often their children, to offer that clinical cardiac screening all in one appointment. And this is helpful in a number of ways. It saves the family time, certainly can streamline their healthcare, and oftentimes family context is really important and valuable in when we're thinking about a genetic testing approach and just communication with the family in general. And then, as Dr. Helwig was talking about before, there's certainly some military context to these discussions that's important to take into account. So at our clinic, we have individualized discussions with patients and families on the implication of genetic information and the policies surrounding that use. Now, even if an individual gets referred out to the civilian setting, there might be providers that are just a little less familiar with this information and maybe not having those discussions as in detail with patients as we would be. Even within our own system, some providers are going to be less familiar with how genetic information can be used and kind of what the protections are surrounding that information. So again, having this multidisciplinary clinic is really valuable in being able to address patient questions that come up surrounding this information. We also strive to provide resources, support resources to our patients. A lot of times that's providing information about a specific condition, providing information about what support resources in general exist, but sometimes that can be providing military specific resources as well. And then lastly, I think appropriate interpretation and follow-up of results and information is something our clinic also is great at achieving. So we provide follow-up over time for updates and testing recommendations. We know the field of genetics is constantly moving forward and there's always going to be updates there, but also really important to follow up on updates regarding results, especially results that are inconclusive, like a variant of uncertain significance. A variant of uncertain significance, or a VUS, is a type of genetic result where we found a genetic change, but we can't tell, we don't have enough information to say whether that genetic change is related to the reason we did testing for that individual, or if it's just benign genetic variation. Imagine it's kind of like trying to do a puzzle with some of the pieces flipped over. And so it's really hard to figure out how that piece fits into your puzzle until you have enough information about it. There's a couple different pitfalls, I would say, regarding variants of uncertain significance that our clinic can help with. So we provide follow-up over time for these variants of uncertain significance and just results in general, because there can be important updates in the reclassification of variants of uncertain significance, as well as other types of results. And then another really important piece to think about when you have a variant of uncertain significance is making sure that you're interpreting that result appropriately. Our clinic talks about what a variant of uncertain significance is and what it isn't, and we look carefully at each time we get one of these VUSs on a report to make sense of what it means in the context of our patient. Certainly, misinterpreting a VUS as a certain or definitive explanation for a patient's cardiac history would be a significant pitfall, and it would be especially concerning in our system, where we know that medical diagnoses can in some cases impact active duty service. So having an individual or clinic that can appropriately follow up on these types of results is really important. And so just overall, our clinic aims to increase access for patients to guideline-directed clinical genetics care while tailoring counseling to the unique aspects of military system healthcare, with our overall goal of reducing preventable cardiac events related to thoracic aortic disease. And with that, I'm going to turn it over to Emma to talk a little bit more about a different aspect of care in our system, which is postmortem genetic testing.
Great. Thank you so much, Austin. All right, as you saw from Austin's slides, our cardiogenetics clinic is really focused on identifying and addressing the risks of thoracic aortic aneurysm in order to try to prevent a dissection from occurring. As you probably know, an aortic dissection is a life-threatening occurrence. There is a statistic that up to 50% of people who experience aortic dissection will die from the event. So for this section, we're going to focus on in those tragic cases where someone does die from an aortic dissection, how can we use postmortem genetic testing to provide life-saving information for surviving relatives? I'm going to start off with speaking a little bit about the value of postmortem genetic testing, and then I'm going to tell you about a program that has been established for military families. We're going to start off with our last poll. So it looked like not too many people on this call have had a family member die from aortic dissection. So you can select that first option, but if you have, go ahead and let us know whether they had genetic testing or not. Okay. And it looks like the vast majority of people on this call do not have a family member who died due to aortic dissection, but among those who did, none of them had postmortem genetic testing, which is not surprising, as we'll talk about in a few slides. So postmortem genetic testing can be incredibly valuable for many different types of cases of sudden cardiac death, including death due to aortic dissection. So finding an answer on genetic testing can have a big emotional impact for families in terms of finding answers for why their loved one passed away. But also from a medical perspective, it can make an enormous difference in terms of understanding which relatives may also be at risk and how best to take care of them to prevent this from happening to other family members in the future. When we find a specific genetic variant that explains why someone died of an aortic dissection, it enables us to test other family members to find out who else is at risk. Most of these conditions are autosomal dominant. There is usually a 50% chance that other first-degree relatives, siblings, parents, and children would also carry that genetic variant. People who test positive have a higher chance of developing aortic disease in their lifetime, even if they aren't showing any symptoms right now. So we know we need to closely monitor those individuals who test positive moving forward. As you saw in Austin's presentation, the specific gene that's affected can also help their medical team know how to best take care of them in the future, as it impacts specific medical recommendations like how soon someone needs to have surgical repair of their aorta. However, despite how valuable and important postmortem genetic testing is, we know that genetic testing is frequently not completed in cases where it might help. We don't have specific numbers for the likelihood that postmortem genetic testing is completed in cases of death due to aortic dissection. However, to give you kind of a sense, a recent article showed that in the last 10 years, postmortem genetic testing was completed in only 3% of cases of young, sudden, unexplained death in NCAA athletes. When a medical examiner is completing an autopsy, the national guidelines recommend saving a blood sample for genetic testing in all cases in which it may be useful. However, this is not always completed, and we believe some of the reasons why include barriers like lack of funding to pay for postmortem genetic testing, and the fact that this technology is new and often unfamiliar to medical examiners. This technology was not widely used among medical examiners even as recently as 10 years ago. So if your loved one did not pass away recently, there is a much higher likelihood that genetic testing was not completed. So what is the likelihood that we actually find a genetic explanation when someone does die due to aortic dissection? This is a paper from the New York City Medical Examiner's Office, and from 2019 to 2022, they had 34 cases in which people died due to aortic dissection. And when they performed a genetic panel on all of these cases that included genes known to be related to aortic disease, they found a clear genetic explanation, which is called a likely pathogenic or pathogenic variant, in 8 of those 34, so about 24% or 1/4 of them. They found a variant of uncertain significance, that uncertain result that Austin just talked about, in 12% of them. So those are cases where we found a variant in a gene that we know is related to aortic disease, but it's not clear yet whether it actually is an explanation for the aortic dissection or if it's normal human variation and unrelated. So something that just needs to be followed up over time. In addition, of those genes that they found likely pathogenic or pathogenic variants in, it was in several different genes, the most common of which was FBN1, which is the gene known to be associated with Marfan syndrome. Here's one additional paper from 2017 from a group in Spain. They studied 17 cases of sudden death due to thoracic aortic dissection and found clear genetic explanation in 4 of those 17 cases. So about 23%, very similarly to the last paper, about 1 in 4. They also similarly found variants of uncertain significance in 5 more cases. Given the importance of postmortem genetic testing, we are part of a multidisciplinary team that facilitates postmortem genetic testing for the military community, known as the MyCap Postmortem Genetics Team at Uniformed Services University. Our team includes the 3 of us as genetic counselors, as well as our adult cardiologist, Mark Hagney, our pediatric cardiologist, Dr. Brian Hughes, and our clinical geneticist, Dr. John Schott. We receive referrals from the Armed Forces Medical Examiner System, as well as other medical examiners and coroners across the country who provide autopsies for military decedents. After receiving a referral, we meet with the next of kin in order to answer their questions about the genetic testing process and explain everything in depth. And then we help the medical examiner with ordering genetic testing from the DHA Genetics Reference Laboratory. We are very fortunate that at this time we are able to provide this service without any cost to families. We facilitate ordering the postmortem genetic testing in appropriate cases, which includes death due to thoracic aortic dissection. We also coordinate and interpret genetic test results, communicating them back to the medical examiner as well as to the next of kin. We meet at least twice with each family to collect family history information, discuss the genetic testing and the implications of the results, provide clinical screening recommendations for relatives, whether or not the genetic testing is positive. As you saw in Austin's slides, screening for a thoracic aortic disease would be recommended for first-degree family members. And we also connect the family with important advocacy organizations like the John Ritter Foundation, as well as several grief support organizations that are a bit more military specific. So during those conversations, many important psychological and emotional issues come up. We meet with families at various stages of the grieving process, from families who just lost their loved ones last week to families who lost their loved one many years ago. Grief is not a linear process and can look different for everyone. Regardless of the length of time since loss occurred, it's important to identify what specific support needs the family has and find resources that can help meet those needs. Many of the individuals that we meet with are struggling to process their own grief while also supporting other grieving family members, such as their children, which can be really challenging. Meanwhile, others who might have smaller families or who might just grieve in different ways also experience isolation or loneliness in their grief. One approach that is helpful to many families is trying to find community through advocacy organizations like the John Ritter Foundation that can provide connection and peer support from people who really understand the experience that someone is going through. Talking to others, family, friends, mental health professionals is certainly recommended to help unpack the various losses that surround the loss of a loved one. In addition, there can be really complex reactions to the genetic testing process specifically. So families are often really understandably worried about the possibility of this happening again to other family members, especially to children. So while genetic testing can be helpful with this, it also has the possibility to reveal uncertain or complex results, like when we find a variant of uncertain significance, or when we don't find an answer at all for a family. In addition, every family is different in terms of their comfort with discussing medical issues, and sometimes complicated or strained relationships can make communicating about medical recommendations really difficult. These are just a few examples of some of the counseling issues that come up in our discussions, but there are many others that might arise, and we certainly recommend that everyone who is grieving consider speaking with a mental health professional if they are struggling. So I wanted to give a broader sense of other indications for which postmortem genetic testing is often useful for. So you can see sudden cardiac death, especially before the age of 40, other inherited forms of heart conditions like certain cardiomyopathies, and then certainly, as mentioned, thoracic aortic aneurysm or dissection at any age. So who exactly is eligible for this program? In most cases, we're able to perform genetic testing if the person who died meets at least one of the following criteria. At the time of death, they either had to be eligible for care within the military health system, which usually includes active duty service members and their dependents, or the person had to have a history of active duty military service at any time throughout their life. We are continuing to raise awareness that this program exists, but we believe that many cases that may be eligible for this testing are not currently reaching us. If you believe that your family member might have been eligible for genetic testing through our program, please feel free to contact us at this email address to discuss further. And for everyone, it can be really difficult to prioritize genetic testing during a sudden loss. We recommend that you ask the medical examiner who's performing the autopsy for your loved one to save 5 milliliters of blood in a purple top EDTA tube for genetic testing, even if it can't be performed immediately. In conclusion, genetics is a critical tool for clinical care across many different specialties, including thoracic aortic disease. The military health system serves a large proportion of the US population and has very unique genetic testing considerations for service members, as well as for those considering joining the military. The MyCap postmortem genetics team is available to help address barriers to access to postmortem genetic testing within the military health system. And clinical cardiogenetics care is available for patients and families within the military health system through the cardiogenetics clinic at Walter Reed. Research to advance our understanding of genetic conditions and the way in which this technology is used clinically to improve patient care is absolutely critical and ongoing. Thank you so much for your time and attention. We're happy to answer any questions at this point.
Thank you. That was so fantastic. I feel like I learned so much, and this will be really helpful for people going forward. And I'll continue to share this presentation as we get contacted by people who may benefit from this information. We do have a few questions here. And I also wanted to mention, as we talked about social support and some genetic counseling considerations, that the foundation does have a peer support program that's free and virtual, all done over the phone or Zoom or text even, where individuals who are affected with aortic disease themselves, or maybe caring for somebody else who is, like a spouse or a child or a partner, or people who have lost someone to dissection, can connect with someone else who has a similar journey. And this is really just listening, empathy, resource navigation. They don't provide counseling or medical information or anything like that. It's just to connect with someone else who can kind of understand your journey. So thank you to Bella for putting that in the chat there. So if that's you or the patients that you serve, please refer them to this service. These are trained volunteers. They do a 3-day in-person training with our cardiologists. So this is a great resource. It's free. Additionally, we are accepting applications for our 2025 class right now for people who want to volunteer themselves. So if that's you out there, February 28th is actually the last day. So you've got 2 days to get it in. Bella, I don't know if you want to drop that link in here too. At this time, I don't believe we have anyone who's currently in the military who's serving as an advocate, although we do have veterans with a history of service. So it would be great to have one. So if that's you or a patient you serve, please send them to us. And with that, let me get to these questions. Okay, I'm sure I missed someone in here, but the emails are in the chat, so reach out, I guess, if you have further questions. But we're 11 minutes past, so I will let our wonderful panelists go because they've already given us so much time today. I appreciate all the questions and activity in the chat and the Q&A. This was really informative for me, really as well. I realized that this is a little bit different audience than we might have for the Foundation's webinars. So if you are a physician or genetic counselor or provider out there who's not familiar with what the Foundation does, please reach out to us. I'm always looking to connect with new partners. We have a lot of free resources for patients and their family members to support them. And then we also fund research. So we're always looking to make new partners. So if this is your first time meeting us, please do reach out to us. And with that, I'll thank Dr. Helwig and Emma and Austin so much for being here and taking the time to share their expertise with us. And I'll see you all next month for Dr. Prakash.